So this will be the last lecture that is included in terms of materials included for the final exam. Um, with all that, we will go ahead and get started. So the title of this week's lecture is Revenue Cycle and Payment. So before we get started, some of you may not be familiar with the term revenue cycle. Revenue cycle is defined as the set of recurring business activities and related information processing necessary to bill for and collect the revenues due for services provided. And essentially, so this process refers to the ability for healthcare providers to to bill and collect for the services that they provide to patients. And so I'm sure just about everybody in the class has gone to the doctor before. And you know that when you go to the doctor, you probably, when you called to make your appointment, you gave your insurance, and that insurance, they bill your insurance, and then after they bill your insurance, they collect some money from the insurance, and then they send you an additional bill. And just the nature of the fact that there are, really three parties involved. So there is the provider and the organization that represents that provider. So let's say, Ohio State Wexner Medical Center. And then you have the insurance company that is paying a good chunk and negotiates prices on behalf of the patient. And then you have the patient themselves. And the mere fact that that relationship exists between those three independent actors makes the revenue cycle of healthcare organizations really kind of tricky, and it's an important process for organizations to really focus on and ensure that they're managing and so forth. And if they don't, it can be really bad for an organization. In fact, there are entire companies out there, and all they do is help hospitals and health systems manage their revenue cycle, and they come in and they specialize in it. So your revenue cycle is a really complex part of running and managing healthcare provider organizations, and so that's why we're going to spend some time on it. So I hope after today's class you'll have a little bit of understanding of just what are some of the complexities around revenue cycle. I could really teach a whole class in revenue cycle. In fact, at UAB, my alma mater, there is a whole class in revenue cycle management. And so, it can be very tedious at times. But anyway, so organizations have to ensure that patients are properly categorized by payment obligations, and then they collect and that correct and timely billing takes place. So if they are incorrectly billing patients, then that's really bad for them, and that correct payment is promptly received. Of the revenue cycle phases and processes. Revenue cycle really touches a lot of different parts of the organization. So the process really starts with scheduling. So when a patient comes in, and or before they even show up to the facility, let's use me as an example. So when I made an appointment with my OB before I had a baby, before they would even take me and let me schedule, they wanted to know what my insurance was, and they took my insurance information, and they went ahead and called my insurance and found out what they could be reimbursed for and what the rates were. And all of that, essentially my pre-registration was done before I even was able to schedule an appointment. So then they scheduled me, knowing what they could get reimbursed for before they scheduled me. And then upon me being scheduled, when I got to the office, I registered also. So I officially signed off on all the HIPAA and billing information and saying that they could bill my insurance. And then we had the charge capture. And the charge capture really actually is based on, what happens at the time of service. So the charge capture is, generally reflects, what did the provider provide me? So what did the physician do for me? And making sure that you are, charging for those procedures. And then next we have the coding and documentation review. So after you've documented what's happened during the charge capture, what happened in a visit, so what procedures took place and what diagnoses occurred or were completed during that time, during the visit, then you have your coding and documentation review. And coding and documentation review is important because it ensures that the services that are provided are coded in accordance with the payer's claim system, and that also the coding reflects the highest legitimate reimbursement amount. And then lastly, the claim is formatted in accordance with the payer guidelines. And this sounds like a big deal, or this doesn't seem like a big deal, but it actually is. So each payer has, their kind of policies and procedures on what they need to see in order to get billed. Medicare and Medicaid, for those who work in healthcare and maybe a part of, may have some experience with this, Medicaid billing is extremely complex, and it takes having someone who really knows Medicaid billing, because if you do it wrong, and you submit them wrong, they just won't pay you, and that's a really big deal. And so you go through the review process, and then once you go through the review, you go ahead and you submit your claims. And when you submit your claims, so you want to submit them to the payer as quickly as possible after the service is rendered. But you also want to make sure that they're accurate, because incomplete and inaccurate billing actually accounts for a large portion of late payments from payers, from the payer companies. If you are part of a managed care contract, you're going to have to review all of these processes within the managed care contract. And then after you submit all of these claims, you next have to deal with the ones that come back because they were denied. And sometimes they're denied because they need more information about the patient, or they need more information about the diagnoses, or something was not done correct. It actually, denial management is a big part of this also. It doesn't seem like it would be, but things get Things get kicked back all the time from insurance companies, where they want more information from the provider. And so after you work through the denials, you'll get a payment, and you'll post this payment to your it'll usually comes in cash, and it reduces your accounts receivables. And then you'll go through and you'll do your AR follow-up to ensure that your accounts receivables now accurately reflects everything that's outstanding, and that you've removed any account receivables that you've actually received. And following that, you'll establish what is left over to be paid for by the patient, and you'll make sure that you bill and collect from your patient receivables. So that's usually the part of the bill that we all receive and have to pay for, and sometimes we're surprised by the bill, and sometimes we're upset by it. But that's, generally the consumer's part of the process. And then lastly, organizations go through reporting and benchmarking. So they look at how old their receivables are, what's still outstanding, and usually go back to some part of the process to ensure that they're actually accurately managing this revenue cycle and moving forward with it. Break it down into 4 different phases. There are the pre-service activities, the at-service activities, after-service activities, and then continuous activities. So pre-service activities include scheduling, registration, and pre-certification. The at-service activities are things that are done at the time that the service is being provided. So these include the charge capture, coding, and documentation review. And then the after-service activities, they really describe all of the parts of the process that happen after the point of service with the patient. So the claims processing all the way through the reporting and benchmarking process. Fourth step, or the part of the process, are the continuous activities. And these generally refer to the monitoring and the reviewing and improvement. So once revenue cycle activities are identified and timing goals are set for each activity, because organizations that are going through that process, they have an idea of how long each part of the process should take. And they implement a system that usually include key metric or key indicators and metrics, and they want to ensure that these goals are met. So they're continually monitoring how long each part of the process takes, and then they're ensuring that these goals are met for the in order to ensure that the organization meets its goals. And then the key indicators that they use to monitor the revenue cycle are continually reviewed with respect to the goals and how these goals are being used to correct any deficits or deficiencies. And they're constantly trying to review the process and make improvements in the process. Now, really, revenue cycle requires constant attention because the external factors that influence revenue cycle are constantly changing. And, problems can occur at any point in the cycle that have ripple effects on, the organization's ability to manage its receivables. And the ability for healthcare providers to convert, services rendered into cash is absolutely critical for their financial performance. And payment collections for services is an essential part of providers being able to survive. Problems with revenue cycles tend to lead to lost and late payments, which can have degrading impacts on the financial condition of organizations. And so think about a provider as essentially, when someone walks in the door, to receive a healthcare service, the organization's essentially lending them money until they get paid for those services. So until the insurance company, sends them the cash for that services, it's essentially a loan out to that individual. And the faster you can collect on that money that is owed to you, in terms of from the person that you lent it to, the better it is for the organization. And so it's really absolutely all of these parts of this process take a lot of attention to detail, and they're constantly being monitored by organizations. Receivable management is a big part of this. So because healthcare services are provided before payment is received, essentially extending a line of credit to each patient, which I just discussed on the earlier slide, each service rendered creates an accounts receivable for the provider. And providers' accounts receivables can accumulate very quickly over time as more and more services are provided. Eventually, however, patients or third-party payers pay the account, at which time their provider receives cash and its receivable balances, decrease and go down. And the management of receivables is an absolute critical part of the revenue cycle, so it warrants a separate discussion. Like I said, these accounts receivables can accumulate very quickly over time because the more business you're doing, the more patients you see, the more accounts receivable you accumulate. And the accounts receivable balance declines as providers receive cash from insurers. So that would be the Medicare, Medicaid, private payers, Blue Cross Blue Shield, stuff like that, and patients. And the management of accounts receivable is one of the most critical parts of the revenue cycle. So the accumulation of accounts receivables and receivables is extremely important. So the total amount of your accounts receivable is determined by two factors: your patient volume and the average length of time between the service and collection. So from the day that someone receives the service, so receives care in your healthcare facility, to when you get paid for it, when you actually collect on that bill for it. So let's look at this home infusion example. I think it's easier to talk in examples. If you think about home infusion, so home infusion provides an average of 10 home health visits a day. And on average, they get reimbursed $100 per visit. So the average daily billing is $1,000. That's 10 times 100. Assuming a 250 there are 250 work days a year. So the company's annual billings of total average daily billings times the number of days is 1,000 times 250 is 250,000. So home infusion has two payers, and this is just for simplification, but they have payer A and payer B. Now, payer A tends to pay its bills on average 15 days after the services are provided. Payer B, on the other hand, pays its bills 25 days after the services are provided. So to calculate the average collection period, the ACP, you would take 0.5 since half the bills are paid within 15 days. So 0.5 is half. 0.5 times 15 days plus 0.5 because the other half is paid within by representing payer B. So 0.5 times 25 days equals 20 days. So what does ACP mean? What did I just calculate? So we're going to go to the next slide and I'll explain it more. Infusion's average collection period, the ACP, what it does is it basically says on average it takes home infusion 20 days from the time that a service is provided to receive payment for services. Now, assuming what this does is it assumes a constant uniform rate of services provided, and what it also means is that at any given point in time, $20,000 of accounts receivables. So, and the reason why I calculated $20,000 is because the ACP is 20, and we know that there are on average 1,000 billings a day, and so 20 times 1,000 is 20,000. So that means at any given time, $20,000 of accounts receivables will be outstanding at any time. Now, what does this mean, and is this a big deal? And so if you are listening and taking notes, I would take a lot of notes on what I'm about to explain. So, it's a big deal to accumulate bills. And so if you think about home infusion, and let's say home infusion just started business, just went into business and just started. So, now, if you just start operations, in addition to, you're carrying $20,000 of receivables, and so $20,000 of billings, it represents a lot of costs to the home health services that are rendered. So you have salaries, you have supplies, you may have cars that your nurses who are providing these visits drive around in that you have to pay for. And so if it takes on average 20 days from the time the service is provided to receive the payment, that's 20 days that you don't have the cash in your hand, right? So therefore, you have to have the funds to pay bills associated with the services before you receive the money that you're going to, because you're going to have a bill come in. And so the funds that are required to pay the bills associated with the services must be obtained somewhere else until the receivables are collected. So a lot of times organizations may use a bank loan to pay for the bills or finance their receivables, which usually has some sort of an interest rate, meaning it costs money. So let's say, that interest rate is 8%. So over a year, the firm has to pay a bank essentially, 8% times 20,000 is $1,600. So that's $1,600 in interest rates just to carry those consistently carry those $20,000 of receivables balance. And so I'm using the term roughly because, I'm just, we're just talking in concepts here. But the reason why it's a big deal for organizations to constantly carry accounts receivables is because it means that they don't have the cash in hand to pay the bills associated with the services that were rendered at that time, and they have to find some way to pay for that. And they usually take out some sort of a loan. And so that is why organizations want to constantly, decrease the number of your ACP, the average collection period, so that there's less time between when you receive the cash to make payment, and you can make payments for for the costs that are associated with performing those procedures or offering those services. Monitoring accounts receivables, if a receivable is never collected, then the revenue is never received. And if the revenue is never received, then eventually, usually after 90 days, organizations have to write off accounts receivables. And this means that it becomes a loss on the P&L statement. So if you go back to, the homework, this was, they report the loss on the P&L statement. And you don't want that to be big. You want to collect all of the revenue you possibly can. You don't want to provide services that you never get paid for. You don't want to have losses. Or write-offs, which I'm referring to them as on this slide. And so one way that you can monitor receivables is to compare your ACP to the industry's ACP. So for example, if you take, our previous example of 20 days, in the home health agency, the average ACP is 22 days, and home infusions rate was 20 days. And so, home infusion is doing better than the average organization in their field. But, you could also go and you can examine each payer's ACP. So, we know that payer B generally collects, or it takes them 25 days to pay a bill. And so one thing that an organization can do, this 25 days is above the industry average. And one thing that this organization could do is try to work more closely with payer B to reduce that time. And sometimes it means building relationships and getting to know the people that you're submitting your bills to, understanding their process, and understand how you can better insert your organization's, billing process into your payer's process. And, again, why is it important to minimize your ACP? And, if you think about the example of, the fact that you're going to have to take out a loan to pay for these, this time, these 20 days that these accounts receivables are sitting on your book, that's money out of your pocket. And it carries a cost to carry receivables. So if you can reduce your ACP by even something like 5 days, that can reduce your annual financing costs significantly. And you may say, oh, it's no big deal. We're just going to take the financing costs. But if you think about, if you think about a large organization that's carrying, say, $100 million in receivables, which for a large single hospital, $100 million in receivables is very common. I mean, think about those who looked at St. Jude. Think about how big those receivables were. And so, if you have an average daily billings of, say, 100 million, which is very easy, reducing your ACP by 5 days, that can save you in some cases, $90 million. $8 million. And so again, it's a big deal. All of these financing charges accrue costs. And I'm not giving you, in these slides, I'm not giving you, in terms of monitoring your accounts receivables, I'm not giving you these numbers on the page because I think that it can confuse a lot of people, and I'm not asking you to know this in terms of being able to show me an example, but I expect you to understand the concept that, that you want to reduce your ACP, you want to keep your ACP low so that you can reduce the amount of financing charges that are associated with, having accounts receivables out, and the fact also in the concept that, that when you have receivables, that when you have receivables on your book, that there is a delay in the time where you receive the cash and can make your payments for all of the costs associated with providing the services. The next thing that you can do in order to monitor receivables, or the second tool, is that you can use an aging schedule. And so what an aging schedule does, actually, we'll go ahead and go to the next slide because it has an aging schedule. An example of an aging schedule. What an aging schedule does is it breaks down the business's receivables by age of account. And aging schedules are important to good receivables management for two reasons. First off, as I just described, the longer it takes to collect receivables, the greater the cost of carrying or financing those receivables is. Thus, aging schedules that show a large percentage of, quote, like these old accounts, so the over 90 days or even 61 to 90 days, imply high carrying costs. Second, accounts that are long past due often become problematic, meaning they end up not being collected and you end up writing them off as bad debt. So you can look at this example. So what, as you see, in the first column, we had the age of accounts. So 20% of all of the receivables are less than 10 days old. 40% are 11 to 30 days old. 20% of our accounts receivables are 31 to 60 days old. And then 10% are 61 to 90 days old. And over 90 days represents 10% of the receivables. So, we're just really scratching the surface on this topic, and I don't mean, again, I could teach a whole class on this, but when we really only focus on third-party payment, but in general, providers, so I didn't focus on how organizations, collect from patients, which is a big deal, but in general, providers have to worry about collecting directly from patients, which is a big deal, and either the entire amount for uninsured patients or a copayment, so some sort of coinsurance that the insured payment owes. And the bottom line is that the management of a provider's receivables is important, and providers need to collect payment as fast as they possibly can from the date that they actually render the service. Systems can be categorized into two dimensions. So there's the payment basis and then the unit of payment. So the payment basis, or the basis of payment, defines how the actual payment will be made. And there are three primary methods. There's the cost, the fee schedule, or the DRGs, and then the fee related, or the price related. So, the 75% of billed charges. So the cost refers to, what it costs the organization to provide this service. The fee schedule, relates back to the list of DRGs associated with what's being provided and what the fees are that they can charge for that. And then the price related goes back to what the insurance company is willing to pay the provider based on the billable charges. It defines how the services provided are consolidated into an actual claim. So there are two primary methods, and we've talked about this a little bit in the past. So there's fee for service or specific services. So this is when individual items that are listed on a claim are paid. And then there's a bundled service where specific services are listed in a claim and are paid in some aggregated basis. So either a per diem, a per day, or a DRG. And DRG stands for diagnostic related group, for those who aren't familiar with that term. So some of the factors that influence pricing are really broken into three areas. It's what is the required net income that the organization needs, what's the competitive organization of the position, and what's the market structure that the organization is operating in. So if you look at these factors, and they all overlap. So at the top, we have the desired net income for the company. And the organization has their own competitive position, which is influenced by the quality of care that they provide, their ability to manage cost and drive costs down, and the amount of market share they have within their market, how capital intense the services that they're providing, and then their payer mix. Payer mix, for those not familiar with that term, it's an important term to understand. But payer mix refers to what percentage of your payers are Medicare, what percentage of your payers are Medicaid, and what percentage of your payers are private payers, what percentage of your payers are self payers or uninsured, and then that's about it. And then on the other side, we have the market structure. So market structure, really talks about, how competitive is the market that you're in? How competitive is it with respect to other hospitals, and how competitive is it for payers? In general, when there are competitive markets in the insurance side and on the hospital side, we tend to see lower prices. When you see markets where there is not competitive markets for health insurance, you tend to see higher prices. So for example, higher prices for hospitals. And what I'm talking about here is that, for those not familiar, or I believe we talked about this already in this class, but, insurance companies negotiate prices with healthcare providers. So if Humana, if you have your insurance through Humana has its list of, their tier one providers. And what they've done with those tier one providers is they've negotiated rates that they're willing to pay each of those providers. And the ability for the insurance company to negotiate rates is based on, what percentage of the market the insurance company represents. So in the state of Alabama, 90% of the market for insurance is owned by Blue Cross Blue Shield. When I lived in Birmingham, when I was going to grad school, there was actually a law in the state of Alabama that there could only be one insurance company. It was kind of crazy. And that law has since been repealed. And so when I got there, the private payer market was even less competitive than 90%. But essentially, Blue Cross Blue Shield of Alabama owns 90% of all, of the insurance market. And what that means is that when they go in to negotiate prices with a hospital, the hospital doesn't have a lot of room to negotiate. They know that they cannot operate if they do not accept Blue Cross Blue Shield insurance. The hospital cannot provide, they can't get revenue. And they absolutely want their hospital to be in the tier one network. They want them to be a preferred provider within the Blue Cross Blue Shield network. And so when Blue Cross Blue Shield of Alabama, says to Huntsville Hospital, hey, here's what we're going to pay you for all of these services, what is Huntsville Hospital going to say back? No, we're not going to pay you for that. Well, let's say Huntsville Hospital says to Blue Cross Blue Shield of Alabama, hey, I'm sorry, those prices aren't enough. We need to charge you, we need you to agree to pay us 10% more on the following services. Blue Cross Blue Shield of Alabama is going to say, sorry, we won't. And if you don't accept our prices, that's fine. We just won't have you as a hospital in our tier one network. And Huntsville Hospital can't afford to not be in the network, because if they do not accept Blue Cross Blue Shield of Alabama's insurance, who else is going, what other private payers or people with employee-sponsored health insurance, who else is going to come in and provide, and make that patient mix and take those services? They're not going to have enough business. So the market structure of health insurance, on the health insurance side, is extremely vital. I think it's pretty obvious that, you want that competitiveness among hospitals, influences price. Obviously, in the scenario that I just explained about Blue Cross Blue Shield of Alabama with respect to Huntsville Hospital, on the same side, if there are a lot of hospitals in one area, and let's say there's an extremely competitive insurance market, the hospital doesn't have as much room to negotiate its prices. So it goes on both sides. One of the most important uses of managerial accounting data is to establish a price for a particular service given a price to determine whether or not the service will be profitable. So for example, in a fee-for-service environment, healthcare managers must set prices on the services their organizations offer. Managers also must determine whether or not to offer volume discounts to valued payer groups such as managed care plans or business coalitions, and how large these discounts should be. After prices are set, managers can then estimate revenues on the basis of the volume estimates. Furthermore, the business's revenue structure, so volume coupled with reimbursement rates, can be combined with its cost structure to forecast profits under a wide range of operating assumptions. So having some knowledge of future profitability requirements with the prices, and hence revenues for attaining profitability, is critical for good financial decision making and financial management of organizations, especially in the current changing healthcare environments that we're dealing with right now. So healthcare providers' power to set prices falls somewhere between these two extremes. No power whatsoever or any price desired. We tend to categorize people into price takers or price setters. But the reality is they're usually somewhat kind of clumped to one side of the spectrum, but not all the way over to the other side of the spectrum. Price takers tend to concentrate managerial efforts or cost structures and utilization to ensure that services are profitable. So the definition of a price taker is a provider that has no power to influence the prices set by the marketplace. So in a healthcare organization, and I would expect you to know that for the exam, what the definition of a price taker is. Again, the definition of a price taker is, and make sure you write this down, a provider that has no power to influence the prices set by the marketplace. So if a healthcare organization is one of many providers in a service area that has numerous purchasers, so typically, your third-party payers, so numerous private insurance companies, and there also are numerous providers, and let's say the healthcare organization, really has little that distinguishes the services offered, and economic theory suggests that prices are set by the local supply and demand conditions versus them being able to set the prices. Furthermore, the actions of a single participant within these situations generally cannot influence the prices set in the marketplace. In a perfectly competitive marketplace, healthcare providers are said to be price takers because they are constrained by and have to accept the prices in the marketplace. Few markets for healthcare services are perfectly competitive. And they have ebbs and flows. Currently we are in a situation in the United States where we have a lot of payers that are consolidating. Four of the major health insurance companies in the country right now are, wanting to merge with a competitor. Are wanting to merge together. So, it is unsure. We're kind of unsure of what's going to happen, in our insurance company, and if those large providers, large insurance companies, are actually able to merge together if the SEC allows them to, which right now, we don't know if that's going to happen. If the SEC is going to allow them to, most likely our insurance marketplace in the United States will become even less competitive. But anyway, as a general rule, providers that are price takers have to take the price as a given and concentrate their managerial efforts on cost structures and utilization to ensure that the services that are profitable. So they can't, rely on efforts to change the the price that they receive. Instead, they have to focus on their ability to reduce the costs that they have and increase utilization of the services so that they have a large volume. So price takers are just concerned about cost as price setters, which we'll discuss later. But, again, the utilization and the cost structure tends to be where the managerial efforts lie with respect to price takers. From a purely financial perspective, a price taker provider should offer all profitable services, even when the market is reduced by discounting other market actions. But it's kind of like a very simplistic approach. Anyway, so the next, on the other end of the spectrum, we have our price setters. So the definition of a price setter is a provider that has the power within reason to set market prices for its services. Healthcare providers with market dominance enjoy large market shares and hence exercise some pricing power. So within limits, such providers can decide what prices to set on the services offered. Furthermore, if a provider's services can be differentiated from others on the basis of quality, convenience, or other characteristics, the provider usually has the ability, again within limits, to set prices on the differentiating services. Healthcare providers that have such pricing power are called price setters. The situation would be much easier for healthcare managers to account for if they had provider status as a price taker, I'll tell you that, or a price setter were fixed for all payers for all services for long periods of time. But unfortunately, your kind of position as a price setter and a price taker, it changes very quickly. So for example, our healthcare markets are ever changing, and providers quickly move from one status to the other. So for example, a merger between two providers can create, sufficient market power to change two price takers to a price setter, as a combined entity. So, if you look at, I'm trying to think of a good market to explain this with. If you look at the Chicago market, on the north side, North Shore and Advocate, Illinois Masonic, are going through a merger right now, and it makes them basically the only provider on the north side of Chicago, with the exception of a few small hospitals. And what this means is that, insurance companies that represent or that want to attract companies who have individuals that who have workers that live on the north side of Chicago, those insurance companies have to, basically have to accept what what this new healthcare organization puts out for a price, because they can't afford to not have their patients, or have their members be able to go to those hospitals, because if they don't, then people will go to a different insurance provider. I'm not sure if I'm explaining that correctly, or explaining that in a way that people can understand it. But essentially, to just reiterate that point, in the case of the merger between North Shore and Advocate, Illinois Masonic up in Chicago, health insurance companies, because they're the only hospitals, the only provider essentially in the north side of Chicago, companies want to will only buy insurance plans that allow their that allow the people in the insurance plan to go to the hospitals that are convenient to them on the north side of Chicago. So therefore, when we see in a situation like this new healthcare organization that has merged together and created this large conglomerate, they're able to set prices in a way that they were not able to set prices before. So after the merger, they became a price setter, because insurance companies essentially have to accept the price that they're willing to pay. So a couple of price setting strategies. When providers are price setters, alternative strategies can be used to price healthcare services. So, essentially, there isn't a single strategy that really is appropriate for all situations. And, I'm essentially just going to present here two different price setting strategies that are most frequently used in healthcare. and this is the full cost pricing and marginal cost pricing. So full cost pricing refers to, and this is a critical concept, in full price costing, prices are set to cover all costs associated with providing services. So the price has to essentially cover both the direct and overhead costs. And in addition to truly cover all costs of doing business, including the economic costs, the price has to include a profit component. So all providers, even not-for-profit ones, have to earn a profit to ensure the ability to replace the assets that is needed and invest in new technologies and expand facilities to meet the growing community needs. And essentially, under the full cost pricing, essentially, like, what happens is, everybody has to incorporate a profit into it, which, I think surprises some people. So, essentially what you need to make sure that you fully understand is that the prices have to include all direct variable costs, the direct fixed costs, and the appropriate share of overhead for an organization. Now, because allocating overhead is complicated, the full cost of an individual services often can be difficult to determine with a lot of precision. And hence, we generally, if you talk to healthcare managers about this, people generally consider these to be estimates of the true cost. And in aggregate, revenues, have to cover both the direct and overhead costs, and hence the prices in total must cover all the costs in an organization. The second pricing tool is called marginal cost pricing, and the definition of marginal cost pricing is the cost of one additional unit of output in an outpatient setting. The cost typically for the supply, so typically only the supplies of one more patient visit on top of the existing volume. In marginal cost pricing, prices are set to cover only the marginal cost of providing the services. In general, this means setting a price equal to variable costs. Marginal cost pricing is usually a temporary strategy because it doesn't cover all the full cost of providing services. Thus, it can only be sustained, it can't really be sustained in the long run, but over the long run, it can only be sustained if the provider recoups the losses by charging more than the full costs of other services. I think marginal cost pricing, in most situations, no additional labor cost is involved. In a lot of situations, marginal cost pricing, can essentially is consistent with the expenses, such as laundry, food, some of the supplies and additional utility services consumed during the day. But the marginal cost associated with one, additional patient day is far less than the full cost of that patient day, which must include all direct, fixed, and overhead costs plus a profit component. So a lot of the proponents of our government programs, so the Medicare and Medicaid, argue that payments to providers should be made on the basis of marginal rather than full costs. But, essentially, these, Medicare and Medicaid, what they say is that, what they argue is that they maintain that some of the price above marginal cost is all that is required for the provider to, quote, make money on government-sponsored patients, and that, that they shouldn't be doing that. But, the implications of that is that non-governmental payers would cover all the fixed costs, or that's what it implies. But, what would happen if all the payers for a particular provider set reimbursement rates at the basis of marginal costs? We would have a big problem in healthcare, and organizations would never fully recover its full costs, and, including the direct and indirect and overhead, and, we'd have a big fail in our system. Perhaps why we've had some of the price problems we've had, in the past. Again, this is usually a temporary strategy. One thing to understand is this concept of price shifting. So price shifting is the act of charging more than the full cost to one set of patients to compensate for charging less to another. It's also called cross-subsidization. This is how, I could spend an hour talking about price shifting, but this is really how our healthcare environment has been successful, how a lot of hospitals have been successful. So, everyone knows that it's kind of like you have a few services that make a ton of money for the organization, and it allows you to operate other services that operate at a loss. So, for example, burn units in hospitals generally don't make money. They're very expensive. They're only used for patients who usually have some sort of a tragedy, and their care, they tend to be they tend to be hooked up to a lot of very expensive machines. They require very intense nursing care. So the patient ratios are very low, which means that you have a lot of overhead. In addition, they tend to require the services of multiple types of very intense specialists in the hospital. So cardiologists, general surgeons, plastic surgeons, and so forth, all, making them very complicated cases. But, what community, you can't have a major medical you can't have a state that doesn't have a burn unit. All communities need them. There are tragedies. People don't ask to be burned. Oftentimes they've been in a car accident or some sort of a wreck or something. And so, communities, hospitals know that you have to have a burn unit, even though they're not profitable. And so what do they do to support the burn unit? Because they believe it's part of the mission of the organization of the hospital. Well, they have an orthopedic, they have their orthopedic unit, and the orthopedic unit tend to make a lot of money. And they help subsidize the losses from burn units. And, a lot of people don't think this is fair. I think that you see this cross-subsidization occurring a lot more in not-for-profit hospitals than in for-profit hospitals. Generally for-profit hospitals don't operate with that much leniency in terms of their mission, so they don't have the ability to keep units that aren't profitable, or don't somehow serve the bigger profit margin. Anyway, it's important to understand the concept of price shifting. But the reason why price shifting, is important is that because in a practical manner, it may make sense for healthcare providers to occasionally use marginal cost pricing to attract new patient groups or retain an existing group. So, to survive in the long run, though, businesses, need to earn revenues that cover their full costs. And this isn't, always easy to do, but essentially marginal cost pricing can be a temporary measure that an organization or the organization can overcharge in another area, essentially price shifting, to make up for the losses of the patients who are undercharged. Historically, price shifting has been used to support services that were not self-supporting. The ER is another example, teaching and research or indigent care. But without using price shifting strategy, many providers would not even be able to offer, the full range of services within a hospital. It just kind of is what it is in our healthcare environment. So the next is target costing. So target costing is a management strategy that helps providers offset the limitations imposed when they are price takers. Target costing assumes that the amount received for a service is fixed and subtracts the desired profit on that service to obtain the target cost level. So, in essence, it's used by price takers. The price or the reimbursement rate is assumed to be fixed, and the goal is to create a cost structure that the service that allows the provider to make a profit. So target costing forces managers to focus on costs rather than prices as the key profitability. To achieve a profit using this strategy, managers usually have to examine, what's within their control. So these costs, how many people does it take? What's the labor associated, as opposed to factors that are for the most part uncontrollable, like prices. So essentially, providers that cannot lower cost to the level required to make a profit, ultimately fail. Um, Management uses this strategy to reduce the full cost of a service to the target level with the goal of continuous cost reduction to eventually push past below the target. Perhaps the greatest value of target costing lies in the fact that it forces managers to really seriously, to take seriously the prices that are set by external forces and look internally at, the underlying costs and services provided. And essentially, to ensure financial survival, providers have to be able to attain cost structures compatible with a revenue stream. The last part of this lecture is medical billing. Medical billing is absolutely 100% critical. Organizations spend a lot of money ensuring that they have people that understand medical billing. And it's a critical part of the revenue cycle, is this coding. So medical coding or medical classification is the process of transforming descriptions of medical diagnoses and procedures into numerical codes that can be universally recognized and interpreted. Diagnoses and procedures are usually taken from a variety of sources within the medical record, so lab results, doctor's notes, radiology results, etc. And it's the basis for reimbursement. The basis for reimbursement is the patient's diagnosis. What else? I'm trying to think if there's anything important. So, I think just in practice, the basis for most fee-for-service reimbursement is the patient's diagnosis, in the case of a hospital, or the procedure performed on the patient in the case of the outpatient settings. And so, I think it's important to have a little bit of a background on medical coding so that you can understand the reimbursement process. To understand is the concept of diagnosis codes. So the International Classification of Diseases, so ICD, is a standard resource for designating diseases and a wide variety of signs, symptoms, and external causes of injury. So these are published by the WHO, the World Health Organizations, and ICD codes are used internationally to record any type of health event, including hospital and patient stays, deaths. In fact, just so you know, the very first ICD code was used in 1893 to report death statistics. Now, the WHO periodically updates and revises these diagnosis codes in ICD, and currently we're on ICD-10. However, it's really interesting. It's a really big deal when they convert to different codes. So ICD-10, came out, I think 2011, but I can't remember exactly. And the Department of Health and Human Services proposed, HHS proposed that the United States would convert to ICD-10 from ICD-9 to ICD-10 in April 2012. In April 2013. Sorry, back up. So the ICD codes, ICD-10 came out in 2012. HHS said, okay, we're going to convert to them in 2013. And basically 2013 came and hospitals said, we're not ready to convert. And essentially it got pushed off multiple times and we didn't implement till 2015. And even when it got implemented in 2015, there were a ton of problems because essentially healthcare providers, are going to wait as absolutely long as possible where they have to make these changes because they're expensive and the conversion is time consuming and costly. And the interesting thing is that the difference between ICD-9 and ICD-10 was that ICD-10 contained five more times the individual codes as ICD-9 did. So it was said to be a lot more, the coding was a lot more descriptive, and the disease categories had been updated a lot. And so, people pushed back a lot. We'll just say that, before they were willing to convert from ICD-9 to ICD-10. Code consists of 3, 4, or 5 digits. The first 3 digits generally denote the disease category, and their fourth and fifth provide additional information about the diseases. So, for example, code 410 describes, code 410 is the code for acute myocardial infarction or heart attack, for those not familiar with that term. But if it's coded as 410.1, it's acute myocardial infarction involving the anterior wall of the heart. So in practice, the application of ICD codes to diagnosis is complicated and technical. For those who work in a hospital or in a healthcare setting in an outpatient office, medical coding is really specific and takes a lot of time. And it's a function that's highly complex, and proper reimbursement for third-party payers depends on accurate coding. And therefore, ICD coders require a great deal of training and experience, and generally organizations end up having to pay these people a lot of money. Our procedure codes. So ICD-10 codes are used to specify diseases. Procedure codes, or referred to as CPT, the current procedural terminology, these were developed and copywritten by the American Medical Association, and they are used by clinicians to specify procedures performed on patients. They are revised periodically, so usually every 3 to 5 years, to reflect the current trends in treatment and procedures taking place. The U.S. federal law requires the use of CPT codes, and CPT coding usually includes 10 codes for physician offices, 5 codes applied to new patients, and 5 codes applied to repeat patients. And the differences in each of the 5 codes in each category reflect the complexity of visits. Now, CPT codes in general, while they're not as complex as ICD codes, and by the way, the law also requires the use of ICD-10, but while they're not as complex, they do require a significant amount of training and medical coding behind the person who's doing it. 10 and CPT codes is essentially that ICD-10 is a code used to describe the condition or disease, or basically the diagnosis, and CPT codes is the code used to describe the treatment and the diagnostic services provided for the services, or the diagnosis, CPT codes are usually updated every 3 to 5 years, and ICD codes are updated far less frequently. And this concludes the end of the lecture. Congratulations, you have no more lectures to listen to in this class. I hope my voice has not been too annoying. And best of luck on the final exam. Please reach out if you have any questions. And, thank you. I've enjoyed teaching this class. I hope you have learned a lot, and I hope you're able to use this information in the future wherever you may end up. Bye.